Okay, if everyone could find their way back to the seats, we'll get started. So we're a little bit behind our stated schedule, but there's I sense from the morning discussion that there's a lot of things that people still want to say. So let's get moving. Oh, Pat's here. Fantastic. I've been asked to chair this panel. I'm going to emphasize that I've been asked to chair it, not to moderate it. So if anybody takes a run at the stage going after one of our panelists, not my problem. Rather, I'm going to sort of, throw some comments, questions at panel members as we go here to make sure that we just hit some of the or pick up some of the threads that we laid out this morning, but we have not tied together yet. So Charlotte is our only returning customer. So maybe if we could just quickly run the table and just introduce each of yourselves quickly to those who are in the room, for those who may not know you, in terms of organization that you come from and your role there. I think that would be helpful. And then we'll jump right into the discussion. Najat?
Hello. Thanks. Hello. Najat Ibrahim, late-stage clinical development at Merck.
Hi, Patricia Keegan. I'm with the Food and Drug Administration. As of Monday, I guess I'm actually with the Oncology Center for Excellence. But recently with the Division of Oncology Products too, which is no more.
Hi, I'm Thara Mitchell. I'm medical oncology, and I oversee the melanoma and skin cancers clinical trial program at Penn, University of Pennsylvania, Philadelphia.
I'm Rebecca Moss. I'm the melanoma clinical program lead for Bristol Myers Squibb.
Hi, Michael Tetzloff. I'm a dermatopathologist at MD Anderson and work with Richard and Janice and team as co-leads for the melanoma pathology group for the INMC.
Great, thank you. So let me just slightly reframe the wording on the agenda here. So we're not going to pretend that there's a Q&A part to this panel discussion. Rather, there's going to be an engagement of the sort of entire participant group as we evolve through the course of little less than an hour. But we are going to start up here. So kind of bear with me as we try to unpack some of the issues that we touched on earlier today with panel members, and then we will evolve into a bit more interaction from the group. So I'm going to take the position, the Vern Sondak position, going into this discussion, which is to posit the notion that we actually haven't established anything yet in neoadjuvant setting in melanoma. So we haven't established clinical benefit to patients in terms of offering them pre-surgical therapy, at least as it pertains to eradicating microscopic residual disease, and that there are multiple things in the clinical care arena yet to be established. Certainly when it comes to drug development, which we've touched on only a little bit so far, but is ultimately, I think, where we all envision this work going. We have a lot of work left to do to set standards and benchmarks and so on. And I would suggest that we try to break down the drug development discussion into two parts. One is using neoadjuvant endpoints, path-CR, event-free survival for that matter, for decision-making in the midst of drug development, as in you are a sponsor developing a drug and you choose to do a neoadjuvant study to help inform whether to go further for this discussion just in melanoma. So that's internal decision-making, internal, if you will, risk-bearing by a drug development sponsor. That's a whole different discussion than presenting ourselves as a field to the FDA, which is what we want to accomplish today, to discuss, where are we? Again, start with the Sondak principle, which is zero, nowhere. We haven't done anything yet in the eyes of the FDA or presenting data to the FDA. But ultimately, we want to have a dialogue today and beyond today with the FDA about what do we need to establish in terms of data. and standards and endpoints that we can ultimately align around, currently premised with our available therapies, which are the ones that have been largely the focus of study in neoadjuvant trials to date. But eventually we all have an appetite for wanting to get into investigational therapies, either on these backbones or I guess possibly as totally new therapeutic approaches. So again, there's a clinical care axis, there's a drug development axis that breaks down into a couple different ways. So I would, kind of suggest that we think strategically about categorizing comments along those lines. And with that said, I think maybe let's maybe go between Michael and Charlotte initially on the topic of sort of setting standards around surgical approach, eligible patients. Is it the already resectable? Is it okay to include currently not considered quite resectable patients? Some of these boundary issues in terms of who should be considered the core group of patients around in whom we need to generate more data, and then turn to Michael in terms of kind of progress on standard setting in terms of pathologic assessment, which we've heard some comments on today, but we want to try to come up with some kind of shared consensus view that we could use across the global melanoma community to get into some common terminology. Charlotte, standards.
All right, well, I'll invoke Dr. Sondak again because we were just talking during the break with Dr. Wargo as well. So the one thing we have not done well in the melanoma community is actually defining what is actually resectable versus non-resectable. And we were saying, we could learn a little bit from our other colleagues, for example, in pancreas cancer, where they really define the amount of involvement of a vessel or other things that would make you, quote, unresectable. So I personally think that the clinical trials should focus on the patients who are truly resectable and not these unresectable patients who are really, as we were saying earlier, really more like stage 4 disease. And then I think the second component is that there is a component of patients that we operate on that we think are resectable that ultimately end up with our incomplete resection. And so, that needs to also be agreed upon amongst us what that number is, because that number is probably equal to the number of patients who progress on therapy. And so, again, this idea that if anyone progresses, that's a negative outcome. I think if we can agree on what a percentage is, I think would be helpful, because it shouldn't count against the drug completely. Those are people, again, who we weren't going to probably help with surgery alone anyway. So.
And in terms of standards, I have to say from the perspective of the INMC and the work that we've done from the pathology team within the context of the International Neoadjuvant Melanoma Consortium, I don't mean to toot my own horn or our own collective horn, but I think we've done a pretty good job of setting those standards. We've made pretty clear definitions of path CR. We've acknowledged a major pathologic response. I think, Christian's data today suggesting that maybe the spectrum of up to and including a partial response, which we also pretty carefully defined, is a meaningful, at least reasonable starting point as an endpoint. And we were pretty careful about following the lead in other organ systems, breast in particular. I happen to work with Fraser Simmons, so he's somebody that informed a lot of that discussion about tissue submission. I think that's a really key point in the trial design, to kind of adhere to the standards that we sort of defined in terms of making sure that you've interrogated the treated tumor bed thoroughly to reliably say how much of the tumor has responded or not. But those are all there. All those definitions are there, and I think represent a good starting point. I also just wanted to say from Christian's discussion, the idea of the Prado trial that I don't know if I'm pronouncing that correctly, but I'm from a small town in West Texas, so we don't really get a lot right. The point is, that is almost like a sentinel node type approach to this, and really enables you to throw the book at that one tumor and really interrogate it, as opposed to having a whole completion lymphadenectomy to work with and submit all that extra tissue in large tumor samples. So I think those are all good starting points. But I think from a path perspective, that the definitions are there, and we're actually with Janice's work and our work with Richard and at the MIA, starting now to identify aspects of that pathologic response that refine patient prognosis in terms of at least PFS. after neoadjuvant therapy in the context of, say, path CR, that you can even get a bump in that with certain features of the path response.
Can you just make one more quick comment, just picking up on this sort of targeted therapy versus immunotherapy discussion that we got into a little bit before?
Yeah.
I gather from what you're saying, you don't feel motivated to create a different definition of pathologic response to suit targeted therapy and immunotherapy. Rather we use the same definitions and then we just see what we hit in terms of
Absolutely, because
results.
the one thing, and again, I'm a neophyte in that respect, but in looking at the breast literature 2-3 years ago, one of the things that struck me was the number of different definitions of what path CR was in some of those early trials. So we actually set out and said, okay, we're going to make a comprehensive set of definitions, and actually it was Christian's input throughout that said, hey, at least mention that we're not dogmatic about the significance of one, and I think Tara's trial also exemplified that, the major path response of less than 10% coming from the lung world, that's reasonable. So I think having those cut points is fine. I think accepting that for a immune checkpoint treated patient, the kinetics may be different than that of targeted therapy. And so whether you have a complete pathologic response at the time of surgery may not necessarily have the same impact or importance.
So Tara, quickly on kind of current standards, where we think we're building in terms of data in the neoadjuvant setting. On the systemic therapy front, I would say it's pretty uncontroversial, I think, that in the BRAF mutant population, if you were to do a targeted therapy neoadjuvant study, then some kind of BRAF MEK backbone would be the thing that you would either compare to or add on. I get the sense from this morning's discussion that there is anything but consensus on the immunotherapy side as to what's our benchmark, or what's the therapy to which we are trying to compare or to build on. And I guess I'm mostly thinking PD-1 monotherapy, PD-1 plus X, where X does not equal CTLA-4, and then of course PD-1 plus CTLA-4. So what are your thoughts about where we are in that landscape? What are our standards? What are our benchmarks? What are we trying to build on?
Yeah, I think I would start by agreeing with your null statement that we really have still a long way to go in that we haven't shown clinical, you said we've shown nothing in terms of clinical benefit. I think that's true because we haven't shown that there's any clinical benefit of overall survival of neoadjuvant versus adjuvant. And similarly, we haven't even shown that there's any benefit of adjuvant versus treating the select patients who develop metastatic disease. So we're really nowhere on neoadjuvant versus adjuvant versus treating stage 4. But I would, in terms of purely clinical outcomes and survival. But I think that there's a huge value of the pace of organization that's happened in establishing some of the standards for assessing path response that Mike has taken the lead on. And I think that in terms of what the standard treatment should be, I would really echo Angie DeMichel's comments this morning in breast cancer. The goal is not to treat everybody with everything. We know from leukemia, the more drugs you give, the more patients you'll cure. But I think that there's an opportunity to be selective in that if you can, we know that, a great proportion of patients will get a CR from PD-1 alone. And if you can select in a tiered approach, as some have suggested with, either the resection specimen or with an on-treatment early biopsy, then escalate to dual checkpoint in patients who have less than the major pathologic response, I would see that as a path going forward. Not that there's a one treatment fits all, but if we can have better predictive markers of response with PATCR and others, then we can kind of start to segregate into groups that may benefit from PD-1 alone, dual checkpoint blockade, or if we have better biomarkers of lack of response there, then could we have patients go on investigational immuno neoadjuvant as well with novel combination?
All right, so we do want to circle back to novel biomarkers a little bit later, but not just yet. So let's keep marching along the progression of the table. So we've flanked Pat with various constituents, but two drug developing constituents on her right and left. So Najat, why don't you dive in on from a drug development perspective, and Rebecca, it'll be the same sort of starting point question for you. How do you see the neoadjuvant space in melanoma as an area in which to play with currently available therapies to better understand biomarkers, or with novel therapies to try to sort of move the field forward?
So thank you. So I think the neoadjuvant space, it's a quite exciting space. And I think it depends on the question we want to answer. One of the questions with which Thara alluded to was, proving or showing a benefit to neoadjuvant versus adjuvant and having those long-term endpoints like event-free survival and OS and all how that correlates with what you see up front and what can be some very exciting early indicators of pathologic responses. So we do have the SWOG study in collaboration with CTEP, and that is ongoing. It's the neoadjuvant Pembro versus adjuvant Pembro. I know that was brought up a little bit earlier, but that's kind of been ongoing for quite some time now, and we can discuss that a little bit later. In terms of knowing, to also Thara's point, if adjuvant therapy is beneficial up front versus waiting later on, we have also ongoing with the EORTC Keynote 54. That with some additional time still it's ongoing, we'll answer that question. Then the other approach for neoadjuvant, which I think was also alluded to, and I think where drug companies can really get a leg up on developing, and what was also brought up today in the breast cancer talk is, have we reached that ceiling effect, right? So we have evidence with PD-1 monotherapy, we have combination checkpoint inhibitor evidence, but what else can we do? What other novel therapies are there and approaches we can take? And I think that's a sandbox where a lot of pharma is starting to look at right now, and how do we do that? And what would really be helpful is, having aligned on and validation of the endpoints that we could look at, and something that would be considered robust, as well as something that, if there is an exciting signal, it could form a pathway for an accelerated approval while we continue to do other studies that get us long-term benefit and, explore into other settings as well. So I think that would be a great leapfrog for patients. I mean, we're doing all this for patients, trying to increase the efficacy. I'd also like to see a nicer side effect profile. I think now that we've demonstrated OS advantage and patients are living longer, we want to also ensure that it's a good quality of life that's achieved.
Great point. Rebecca?
Oh, thank you. So in terms of, you sort of asked two questions. One is about the I-SPY approach, which is obviously the envy of all the other tumor types. And whether or not neoadjuvant melanoma is the place to do that, to really look for a signal. And that would be very tempting. But I also want to bring up that we are in a position right now in melanoma where we have a strong signal of efficacy of a currently available therapy. We know that a combination of anti-PD-1, anti-CTLA-4, nivolumab, ipilimumab has shown excellent long-term benefit with 5-year overall survival. We're seeing that reflected in the Immuned data that was presented earlier today, for resected stage 4, and also in a lot of the data, particularly from Kristen's data from Opus and Opus and Neo. So using the neoadjuvant setting to explore new mechanisms, while very tempting, this is a small patient population with a very high unmet need and a very high likelihood of recurrent disease. And I'm more interested in this point in how we can use the existing therapies to show long-term benefit for patients, the long-term benefit that we expect so far from the pooled data. Earlier today, Dr. Amiri Kadahari had mentioned that we can translate from the neoadjuvant setting to later settings in drug development, but I feel like at this point we need to learn how to do reverse translation to bring these therapies earlier in the stage of disease, which has a lot of potential benefit to patients, potentially a shorter duration of therapy with potentially less cumulative toxicities, potentially some less morbidity of surgery. And so that translation, how we can bring effective therapies earlier in the stage of disease, is, I think, the real challenge for us, because although they are approved in later stage of disease, that doesn't mean that our patients have access.
Fair point. So Pat, to you, at least for initial comments, we'll keep coming back to you, I'm sure, as other people in the room make comments that have regulatory significance. In the discussions we've had so far today, I won't pick on anybody by name, except perhaps Christian. I'll pick on you by name, wherever you're sitting. There's a bunch of moving parts in a lot of the early studies that are ongoing now or about to be ongoing, including duration of post-surgical adjuvant therapy, and then the duration of pre-adjuvant pre-surgical therapy as well, and then now jumping into investigational therapy, concepts as opposed to just continuing to build more data with available therapies. So if maybe we could take a step back using the Sondak principle of we haven't gone anywhere yet as a field. What do we need to generate as a community and kind of from your perspective to have some understanding of what the relationship is between pathologic response, event-free survival, and let's say overall survival if it's feasible. I mean, how much data, maybe borrowing from the breast cancer experience, what constitutes a true foundation around which we can then have a conversation around certain endpoints for novel therapies, because I think we don't want to jump to that just yet in this discussion.
Right. Well, and I think part of the thing with the breast cancer was they were trying to determine if there were enough data with 11,000 women to determine whether or not this could be considered an established surrogate.
Yep.
And we wouldn't necessarily ask for, I don't know, was it 10, 12 trials and 11,000 people for a surrogate reasonably likely, the kind that would support accelerated approval. I think that the kind of data looking at correlations can support a surrogate endpoint for accelerated approval differently from the data that we would need to say, this is an established surrogate, we will accept this, that you have established this correlation in randomized clinical trials. So I think one of the issues is, what do you want to use this for?
Yeah.
Is this for an early assessment for accelerated approval with the intent to go on and verify the benefit, or are we talking about we do this and we're done? Right? So I think that the kind of approaches that have been done, looking at outcomes in people with and without responses, is useful. I am concerned that the number of patients in each of these individual studies, although they seem to be consistent with each other, are all very small. And whenever we get very small studies, we tend to have a lot of creep in terms of who actually went into the study, how representative are those people. The confidence intervals around, the observations are very large, so that, you're not as certain of those relationships. And so I think larger experiences would be helpful, and additional trials, randomized trials, if you have them, are always nice. But I mean, some of the data that we have now is a good start towards getting that. I think one of the concerns that I had also in looking at the data is that I was less convinced that a partial pathologic response had the same significance as the majors or the complete responses. And we would like to see those data. And I may have been not correctly interpreting the data as it was going by it, but it seemed like pooling them in when there was a relatively small proportion of that composite probably overestimated our confidence that that's telling us something, whereas where when people broke it out, it appeared to be different. And also the people did appear to be using different definitions. So a little bit across those studies, that not everybody approached it the exact same way. And so I think another issue would be, has the community clearly adopted the proposals for assessment of pathologic response as laid out in the paper? Is that something that everybody in the community will adhere to or not? And have we had feedback on that? Because I think standardization of that will also make it easier to interpret these trials.
I mean, it's a great point. I would say that the trials that have come out recently, so trials led at MD Anderson with Rhoda Maria and Jim Wargo and Hussein Talbi, that are all INMC driven. Christian's work and the MIA's work, all INMC driven. And so that effort that really that Rhoda and Hussein and Jen and Alex Menzies and Georgina Long have all led with Christian to standardize the approach to pathology, those trials have absolutely, I mean, I've done them from the path perspective at MD Anderson, so I can unequivocally say that they have. Now, the enthusiasm in the community to look at 30 blocks of necrotic tumor versus 5, I can't speak to that. I can't encourage people to, I'm not going to moralize. I can't. I can say that if you look at the data and you see the importance of it, at least the preliminary data, and I respect Dr. Sondak, so I understand that point, but I think if you see the preliminary data and you see the value in designating a path CR and you see why it's important to interrogate all that tissue, for me, I'm enthusiastic, but I can't speak to how well the community is going to adopt this and be enthusiastic. I would just add again that the Pareto idea of having a little bit more of a focused piece of tissue to interrogate may, soften some of that potential resistance. But
Right. But that would be another thing, would be to have general agreement on the approach, how to characterize it so that it's apples to apples across studies. Not that they're hugely disparate, but there are some disparities, right, in terms of how one might have done. So we would want to know that they are consistent across so that we can feel more confident in pulling that. Similarly with things like, how did one define event-free or relapse-free survival and the similarity there. And, there are some groups that have a long history of doing that, but I don't know that from group to group, it has always been exactly the same.
So I can't speak to the clinical definitions, but I can unequivocally say from the pathology perspective, I traveled to Sydney in December last year, we pooled our targeted therapy patients and we reviewed every single patient together, including the gross description and the tissue submission. And that was the whole purpose of the INMC, was to harmonize and homogenize that set of data to facilitate pooling of these smaller trials.
So it seems all well and good for major melanoma centers, but we're now at the beginning of the era of cooperative group investigations, at least, that are likely to enlist a more diverse set of centers. And I guess some of this can be ironed out, these discussion points with central pathology review, in these large multi-center studies, but can't be easily ironed out if there's actual decision-making happening in real time based on the pathology assessment after surgery, which is to say if they're either outside of the trial, so just sort of bootleg decision-making, or inside the trial, like intrinsic decision-making driven by local pathology assessment. What efforts have been undertaken, that you're aware of in these sort of more broad-based and community-engaging studies to try to come up with some rules, common rules of engagement?
Absolutely. So I'm actually doing the pathology review on Dr. Sapna Patel's SWOG trial. And so there's been a tremendous amount of investment in terms of responding to emails, referring them to our paper, sending them diagrams, talking to people about the importance of how they submit that tissue in a uniform fashion. That's my N of 1, but it's going to be a lot of patients. So it's a ground level grassroots type project. I don't mean to, we'll leave it political alone. But I don't know any other mechanism to do that other than to inform people of what we're trying to do and why we think it's important. And until we're proven wrong, this is sort of our best guess at the approach, to educate the community and to it's written in to the protocol how we want the tissue submitted. How we want the tissue submitted, and how with the diagrams and with the rules and sort of regulations put forth in our pathology white paper.
Can I say something?
Mm-hmm.
It works, yes. There is something that I think we forgot to say, that even if it seems a little bit obvious, we learn from the metastatic setting. What have we learned? We've been looking forever for a biomarker, predictive biomarker for long-term survivor. The best one is complete response. But we cannot do a pathological verification at each metastatic site. So we have to wait. Sometimes we do PET CT, we do a biopsy. But this is clearly the best marker to know that a patient is going to survive. It works for targeted therapy. We cannot stop the treatment. It works for immunotherapy. We can even stop the treatment. So it's not very surprising that a complete pathological response is a good biomarker. We are in another dimension. We can have the verification under the microscope, but it's very similar to what we see in the metastatic setting. So it's quite logical, and I think we should really think of that when we try to really ask ourselves, will it be a good marker? It's obvious that it's going to be a good marker for long-term survival.
All right, Christian, go ahead. I was picking on you.
Concerning the pathological analysis, I'm not concerned about that the pathologist will look at the slides as requested by the INMC, but I'm more worried, and that we have seen also in our center, that they do more than what they are requested. And what happens then, they see this response after 6 weeks, are totally enthusiastic about, and then suddenly cut everything off your sample that you wanted to use for translational research, and then they find one half-dead tumor cell. And then they call it no PCR. So, and therefore I want to strengthen on, first of all, to teach our pathologists to do it really in the way that they have done it before. And the second thing is, therefore I'm hammering also on that we should not focus completely on PCR, because if you look for it so deep, you will maybe find one cell. But this you might find also in my lymph node here when you take one lymph node out from me. Because what we know is that we have always some cells. And this is the danger if we say make PCR the holy grail of neoadjuvant immunotherapy. And I would like to really advise you to go for the major pathological response. Yeah, this gives the buffer for the deepness what the pathologist in sein over-enthusiasm will have a look.
Yeah, well, of course, the melanoma field's been through this for 20 years now with sentinel lymph node biopsy and pathologic assessment of sentinel lymph nodes in terms of the degree to which pathologists will go looking for that single cell.
So perhaps it's fitting in the shadow of the Washington Memorial that I've become a human Rorschach test. I want to be clear. I never said that. We've never proven anything. Some things are proven with one patient. We've proven with one patient. Charlotte's proven it. We've proven it, that you can take a tumor that is completely unresectable without amputating the extremity and treat that patient and have them undergo surgery and be a long-term survivor without any additional post-operative therapy. One patient proves that, and they didn't even have to have a PATH-CR to get there. I agree that PATH-CR, we've established how to do that in a very reproducible way, but I also agree we don't know for sure that you have to have every last cell. We do know for sure, we've also proven that if you look harder, you find live cells sometimes. And so maybe the actual cutoff is 88% dead, and how reproducible is 88% versus 89%? That's the things that we don't know. We've also proven that sometimes the biggest tumor containing lymph node is histologically negative after treatment, and a microscopically normal appearing lymph node has viable tumor. We've proven that because one case proves it's not a 100% correlation, but we don't know whether that means you couldn't spare that patient an axillary node dissection safely and salvage the few that recur. And therefore, even a study design in which only a biopsy proof of one thing says you can't do surgery, we have to recognize it contains an implicit assumption that the people who didn't have that response might not have done just as well without having surgery. So my point is we have to understand that we haven't proven everything, and that we are taking an awful lot on faith and the power of the observations that we have made, the proving that we can fix things that we couldn't fix before, the proving that we can get such a high level of pathologic complete responses leads to tremendous enthusiasm, but it shouldn't lead to an extinction of our willingness to question what are the exact best ways to go forward.
For that we do the trials. But I'm worried also about another thing. The community is meanwhile so enthusiastic about neoadjuvant trials that I know for sure in Brazil, in Germany, in the US, it is done already outside trials. And this will hamper in the future the inclusion into trials.
Yeah, this is part of what was motivating my question to Tara before about, how enthusiastic are we about the currently available therapies, as neoadjuvant treatments, including Ipi/Nivo. Go ahead.
I think want to just highlight one important clinical endpoint I think that could be practice changing and possibly could lead to a, let's say, regulatory approval, et cetera, is the percentage of patients that we will ultimately save from having surgery altogether. So similar to Mike Atkins' patient where we treated, that a PET CT scan completely negative, and then we say, should we subject this patient to surgery or not? So it should be something built into our studies, doing these imaging studies. A simple PET CT scan can be done in the community. And then, of course, in the context of a study, we will have to do surgery, confirm the pass CR, and then look at the relapse rate at 2 and 3 years and say, well, these patients 3 years out did not relapse, should not have surgery. So something we should, kind of.
Right. I do. There was the other thing that I didn't bring out and that we didn't talk a lot about is that we're all patients managed in the same way in these outcomes where we're saying, oh, it's all correlated with correlates with EFS, but what else happened to these people along the way? And did they all get managed in the same way, or are there other confounding factors that could explain some of these differences? And to the extent that we have a lot of individualization of the post-treatment post-surgical resection therapy, or even, surgical, whether you get surgical resection is what you're suggesting, I think it makes it more and more difficult to answer the straightforward question of, is this drug alone responsible as a neoadjuvant therapy for all of these outcomes? And so I think you have to think carefully before you begin to have a lot of not that it can't be built into a trial adequately designed, but you really have to think carefully about ensuring that you are controlling for confounding factors, like who doesn't go to surgery or what kinds of additional therapy happen afterwards. And I think that that is an issue. First, we should look at in the data that you have so far, and then you would need to consider going forward in trials. You would really need to take a hard look at that. That's a different question than does this do that? And I would caution you against trying to answer all questions in few trials.
Wait.
Sorry about that. So I think I totally agree. And I think in this case, it's a simple question. How can we save patients from having surgery by doing a PET CT scan? As simple as that. But I agree. I mean, it's a lot of confounding factors. It has to be done in a study. But questions like these that are practice changing, that are economically also useful, et cetera.
But we have to at some point agree on reducing to a bare minimum the number of moving parts.
Yeah.
I mean, otherwise we're we're never going to get there. I mean, we lost Angie D. Michelle. I was going to ask her earlier, what percentage of potential candidates for neoadjuvant therapy at these centers that are part of I-SPY go on the I-SPY trial? Whatever the number is, we need several-fold higher yield, at least in our centers, of patients going on these studies. Right? So if we have 90% of patients bleeding around getting neoadjuvant therapy outside of a protocol, we enroll 10% of potentially eligible patients. A, we'll never get there. B, there'll be so many confounders that we'll never possibly be able to wrestle down these issues about what's the ground truth relevance of path CR if we're not even doing the surgeries to
And then the other
establish
thing
it.
is the magnitude, because you have the luxury, unlike with breast cancer, of having very high response rates, pathologic response rates now, but you've got a high ceiling. So an add-on is going to be really, really challenging to look at. If you bump it 10%, an absolute 10%, what do you make of that? So I think here you actually have a lot of advantages over lung and breast and some other places where these response rates are not being seen pathologically. Right. So you are more likely, just based on the sheer effect size, to be able to show what you want to show. But it's not going to be, you have to consider the context that once you do it once, it's always in the context of the magnitude. Yeah. So even if we said, a pathologic CR rate of 50% is likely to correlate with EFS, a 10% is probably not, and so you have to build all of that in as well.
Right. Hold on. Wait, Alad's been waiting patiently with the microphone.
It's just a clarification.
Okay. You don't have the microphone.
No, it's only because it's that.
Sure, I believe you.
Thank you. You can trust me. No, but really just from the clarification, because I think it is critical for the field in relationship to establish a roadmap in relationship to correlating potential surrogates such as PathCR to event type endpoints. So you just threw out two examples, a 10% delta versus a 50% delta. And one may be positive, one may be less correlative. But the truth is, we don't really have a good sense in relationship to how to make that prediction. So what do we think are good parameters by which to then define, and in particular, when we have actually no baseline, there is no accepted standard of neoadjuvant care at the moment. So then how do you define what is a threshold? And it's obviously not a numeric number that we can just pull out of the air, but there really needs to be some criteria by which we can start to build that story. So I'd just be interested in your thoughts.
So, and I might ask if Raji's still here, she can help us, because I think you have to work back from the data. The data that you have will help you explore what that is, and then you can prove it going forward. But I think you have to look at your data and see. I mean, you guys are suggesting that there are very large effect sizes based upon what you're observing in this somewhere 50, 60, I think one was pretty close to 80% range, you know, that there were large effect sizes, and you start from there. That's all you can do, is start from that point, and then design the trials according to your assumptions. But
yeah, sorry. Oh, okay.
Alon
Sharon, NCI. So, I just wanted to, just following on, I think, on the points that Dr. Yang and Dr. Keegan were making, I think that, we have to separate out the idea of neoadjuvant therapy actually improving something that's real, that we consider event-free survival, from decisions that one makes from a drug development perspective. Because I think we're all buying into the Kool-Aid, I guess, or into mixed metaphors, that we can actually use PathCR or improvement in PathCR to make decisions in terms of drug development, to look at new ideas. That doesn't necessarily mean that we have to think about each of those trials as the next regulatory approval trial. What we probably need to do first, just to make neoadjuvant therapy that much more useful, if we believe that it's going to be, something that we want to make standard of care, is actually to push forward on a trial like S1801, which actually takes those patients, getting some sort of standard of care, pembrolizumab, versus neoadjuvant therapy, whose endpoint is not PathCR, whose endpoint is event-free survival, that then you can use all those patients that Michael Tetzlaff and Janice Talaby worked very hard to actually put together and see how those 500 patients actually do, or the 250 anyway on the neoadjuvant arm. And that's how you build. And yes, at the same time, you can certainly have a neoadjuvant platform. There's no reason why you couldn't. But you can't run before you walk. You really need to actually, I think at least from the regulatory perspective, that you have to push forward the establishment of neoadjuvant therapy with some sort of randomized trial correlating to something that you believe is an important clinical endpoint for patients.
Yeah, and it's critical for drug developers, right? We need to build upon the data, and I know there's been a lot of talk about regulatory strategy, but I think we still have a lot of work ahead of us to have large, controlled, randomized studies that are done in a way that there's a consensus on, and that should be established between academicians as well as the regulatory bodies that will be looking at this in order to later on be able to build upon that and catapult, right? And I know the FDA and other agencies will also look for, like you alluded to, Pat, to build, right? So contribution of components. So what is a PD-1 monotherapy doing? And when you add on a second agent or a third agent, what is that achieving? Do you need those or not? So there's a lot of steps that and boxes that need to be checked before you get a regimen or a single agent approved. And I think that's a separate question and a separate set of studies that may need to be done. But I think if the field as well as the regulatory agencies with cooperation from sponsors can agree that this is a systematic way of how we're going to do this. I think the pathologic response question, that's going to require a lot more data, more patients. I think you'll need to see, as Pat alluded to, how is that going to translate long term? But for that, you need a lot of patients and studies that are done the same way, right? Or one big, large study. And then I think the agencies can then be acceptable to some cutoff that we put in there. And then you can build upon that and see what other agents can help to improve that efficacy. So I know there's a ton of enthusiasm and excitement in the field, and we feel it as well. And, obviously, we're committed to wanting to move the field forward. But I think a key takeaway from today, and at least from what I got, I think this is just one of the still young first steps in establishing the field. And I hope, that this continues forward with further discussions. And, globally, we can align on something that the agency may smile upon.
All right, Christian, one more comment, and then after this, then we're going to pull you up here on the panel so that you can't actually just grab the microphone. We can regulate your access. So you first, and then Robert.
Okay. I think we are a little bit further than Najat says, because we are thinking already about an adjuvant, a randomized trial that might be interesting to the FDA. My question, this is for Pat, I'm really struggling indeed with these confounding factors, because we will have something about in the range of 80% response rate from the Ipi/Nivo neoadjuvant treatment, but we have 20% of patients that are non-responders. And every physician that can think will change this patient, the non-responders, to adjuvant BRAF/MEK. So now the question is, shall we make a trial only in BRAF wild-type patients, and assuming that it's even effective, or the results that we get from neoadjuvant holds true for the same for our BRAF mutated patients? Or shall we include all patients and do then a planned subgroup analysis? What is more worth for you? As a planned subgroup analysis, or a smaller group of patients, and then you assume that can be translated to the whole population?
So this is really a discussion far and above what we are, all these scenarios. We can't go through every single scenario. I would suggest, but I would suggest that, for instance, your statement that everybody will automatically get switched to the other, we'd like to talk about, is that a universal thing or not? We wouldn't suggest that somebody does an infeasible trial, but we would have to talk about what are those factors and where they're going. And we would also like to, and again, this is kind of going back to the primary data, which we've seen in general, the data that you're all relying on, but there's a lot of things we don't know about what these studies can have shown us. And in part because we don't know a lot about the people who went into these trials and how representative they are. And, as we're moving forward, is this, CR rate of 60-80% representative of everybody with regardless of the tumor burden, regardless of the size of the largest lesion, right? So before you go on to develop the next trial, we should interrogate this data set that you have, continue to get some data to figure out, because the drug companies are going to rely on these assumptions to set up a trial. Yeah. And if they don't understand all of this data, they're going to have the wrong assumptions, the wrong trial design, et cetera, to go forward to look at this in randomized trials. So I think we do need to look at a little bit more. Things like about, do you include the BRAF patients or do you not? What is the impact of doing that? To talk about that a little bit, I think, are things that the group has to look at and say, these are we've looked across all these available trials, as the trials read out, these are the factors that are important to consider, to control for, so that when we design a really definitive trial, we know that our assumptions are fairly reliable.
They were all comers. And I invite you, I show you everything, and I think the INM is more than happy to give all the data to the FDA.
Robert?
So I want to comment on a few things. First of all, Vern, Ahmad, and Christian, and Mike Atkins also. So a number of things. So I'm speaking as a surgeon. So as a surgeon oncologist, we really have to think about these patients. Who are these patients that go onto these studies? And you pointed out that, Patricia, and all of this. I think that also with that, what Ahmad was saying, that we're trying to get away from surgery. Well, many of these patients who have a 3-centimeter lymph node in the axilla, the surgery is actually very feasible, and the risk of recurrence for many of these patients is exceedingly low. Now, the surgery itself has fairly minimal morbidity and no long-term morbidity. However, if you do then combination immunotherapy for these patients, they may have long-term side effects that they would not otherwise have had. And so I think that you really need to look at this. And I don't agree with you that we're trying to get away from surgery. I think we're trying to figure out who are the best patients for each of these modalities. Well, so you have the adjuvant therapy for them, but it also, I think there's a part of that as well, is that we're talking about this, and Christian also, I think that the data that is coming out is very encouraging, but we need to look at who are these patients. And for the opposite as well, many of these patients had severe adverse events, never got to surgery, and many of these patients may not necessarily have needed any of this therapy and could just have had the surgery. So before we do all of this and we talk about registration and so on, I agree with Patricia. We need to figure out who these patients are. And Mike Atkins pointed out earlier about the kinetics of their disease. I think that's an important factor we have not spoken about at all. Sort of bring that in. What is the kinetics of this disease? What is the likelihood of this patient actually progressing, even on these therapies, with and without surgery? So.
Oh, no. Let the record show that Christian is going for the mic a fourth time before Jeff Sossman has said anything. I just want everyone just mental note.
Robert, you don't read these papers. These were all macroscopic disease patients. You have seen the curves of that. These patients have less than 50% overall survival. So it's really overstating that the surgery is here the best treatment. Yeah, I agree with you. When you have a 80% overall survival by surgery, you can state this. But this is not fair to the patients if you claim that you cure these patients. That's not fair.
No, so Christian, I think you missed the point. That's not what I'm saying. No, what I'm saying, Christian, in all of this is that we need to understand who these patients are. That go into these studies. We need to understand what is the kinetics of their disease before they went on. What was the mutational burden? I know you're showing some of this data, but again, with this also then to say that like I was saying, we get away from surgery altogether. There are some of these patients that really all they need is surgery, and we have to remember that. And I think that both of you are great, but you look at this from an advanced stage 4 disease perspective, not necessarily from a small stage 3 surgical perspective. Additionally, Christian, as well, I think that we have to look at the economic aspects of this. So we have not talked about that. Many times, this surgical resection is economically very inexpensive, whereas some of these other therapies are not. So these are factors that we need to look into as we develop this. I'm going to give this to Jeff now.
No, Sossman has to go now. Come on. You can't end the session without Sossman.
Okay, first, I think all of these points require some standard evidence that we can, I think the data is great as it is, small numbers, and don't tell me every center is doing exactly the same thing. So I think surrogates we need surrogates that are imaging or biopsy related or even blood. But that has to be done in the context of some clear definition of whether it works or not. Mm-hmm. And so I think that was my first point. Second, I'm concerned that while there's a lot of discussion what's best and what's not best, that if we let this simmer and we take time, this trial won't get done at all. We all know that those trials that get done are those that are pushed through at the time there's a lot of interest. And as the community is convinced that neoadjuvant is better, we'll never get that answered. And I think that has to be thought of quickly, not delayed.
Right. We're trying not to discourage you from saying we would consider this because this is, but we want to do it carefully enough so that we don't blow it. Let's put it that way. Okay. So I think we do want to know that people have looked at the data enough to feel like they're understanding what limited data there are before they go forward.
So I wanted to change the topic, although I am for Medicare for all, but I just wanted to change the topic to what was brought up before. And that is the sequence of having to prove that neoadjuvant therapy is better than adjuvant therapy before using neoadjuvant treatments as a platform for trying to identify which combinations of treatments would be the best to move into the metastatic setting. I see those as completely separate, and you could develop those platforms even if it turns out that neoadjuvant therapy doesn't have a better survival than adjuvant therapy, as long as it's not a worse survival. And I think we already know, although the numbers are small, that a combination that has event-free survival advantages in the adjuvant setting in stage 4 NED patients also has higher pass CR in the neoadjuvant setting. Now, we can validate that with more numbers, but that suggests that we might be onto something. And so if we could find a combination that had 80 or 90 or 100% near CR in the neoadjuvant setting, then that would be something that would be really worthwhile testing in the stage 4 setting instead of the random way in which we're choosing those combinations now, and we can't study all of them in every in the patient population that we have.
No, don't give it to Christian. One last word is going to go to Vern Sondak, since we picked on him and he hasn't had many chances to defend himself. Last word goes to Vern, and then just to remind you, there's a meeting at 2:15 in this room that is, roughly on this topic. So all the enthusiasts just stick around for the next meeting, and we're going to take that over for the novel biomarker discussion.
I just want to bring up another point. Tomorrow, the next patient that I see with resectable disease in his axilla is a patient who is going to have failed 6 months of Nevo that he received after his positive sentinel lymph node biopsy. And that is the stage 3 resectable disease of the next 5 to 10 years. Not these people who are coming in de novo, and not people who failed adjuvant interferon. We've got to also figure out what to do for patients who've already seen a single agent anti-PD-1, is giving them anti-PD-1 again plus ipilimumab going to do anything for them? If they're BRAF mutant, is that different? So there are huge challenges that still remain for this field, and I personally think that neoadjuvant therapy is absolutely appropriate for virtually any patient with measurable disease in their nodal base. Now, I am not concerned as a surgeon that I'm going to miss some mythical resectability date if we are following these patients carefully. But I do think there are tremendous oncologic and pathologic questions that we still have to address and resist the temptation to think we've already established things beyond a doubt, and be open to look at new things, and including using this as a wonderful platform for prioritizing drug development.
Fantastic and wise concluding remarks. Mark, come on up. Thanks, panel members, for your comments.
Very good panel. So, thanks. I just wanted to say, I think that this has really been a dynamic conversation today. Obviously, things are changing, and it's a rapidly changing field in neoadjuvant. I think that this is, I wouldn't say the start of a dialogue, because we sort of have started it a few different meetings ago, but I'd say that this is a continuation of the dialogue. The MRA, the FDA stand ready to continue the conversations for individual companies or academic investigators that want to meet with the FDA. That's their role. They invite you to come talk to them about your trial design. They'll give you much guidance. I think this is really a critical dialogue in melanoma, and I think it was very helpful to hear from breast and lung and some of the speakers that talked about what's going on in bladder and other cancers. I think really the whole oncology field can benefit. And, I'm just pleased that all of you joined us today. I did want to mention there was about 130, 140 live web lines open out there in the world, and that doesn't equal the number of people, because I know one room in Australia had 10 people in it. People during the middle of the night have been watching us. I know a group at Johns Hopkins had a handful of people in the room. So I think several hundred people in and out of this room have heard this conversation and dialogue, and I think this will be wide-ranging, the impact that it will have. And lastly, I should have started the day with this, but I did want to thank all the staff that have made this happen. People at the FDA and the MRA and Dr. Topalian have worked really hard all summer, gave up most of their August to make this happen, as well as all the speakers and panelists we've had throughout the day. But thank you to Janine and Sonia, Janine on the MRA staff, Sonia with the FDA, Diane Spillman with the FDA, who's not in the room with us today, and other colleagues, Mark Thuray, Ashley Ward, and Stephen Lemmer. You've been great, and Pat and Lale and the other speakers from the FDA have been wonderful to work with. And then the MRA team, Michael Kaplan, our CEO, Cody Barnett, and Tyler Brown have made all of this possible. And Kristen Mueller. And really, it's been a remarkable day for me. Some of the outputs that will be quickly coming from this in the next few days, the whole entire webcast has been videotaped and will be archived on the FDA and MRA website. The PowerPoint documents will be shared in PDF format on the FDA website in a few business days. There's a couple of you that need to remove unpublished data from your slide set. Jen Wargo, I'm looking at you. And because this is going to be published on the FDA website, but we'll put redacted near final sets on the FDA site. And the MRA and FDA teams and Suzanne are going to work on a manuscript to come out of this meeting. So I think it will have some wide-ranging, long-lasting external impacts. And really thank everyone for your participation today.